Okay, let's talk about chronic pancreatitis. It's one of those really tough, complex conditions that can be a huge challenge in the clinic. So, in this explainer, we're going to build a super high-yield framework to help you nail the diagnosis and management, hitting all the key points you absolutely need to know for your patients and, of course, for your board exams.
So here's how we're going to tackle this. We'll walk through it just like a real clinical case. First up, what exactly is chronic pancreatitis? Then we'll dig into the causes with TGAR-O, figure out the best diagnostic approach, talk about managing pain and insufficiency, and finally wrap up by navigating those major complications you're bound to see.
All right, let's jump right in. First things first, we've got to lay the foundation. Before we can even think about treating this thing, we have to get a solid handle on what makes it tick, and what really fundamentally separates it from just a regular old case of acute pancreatitis.
So, picture this, your patient comes in with that classic story, right? That chronic gnawing belly pain. And your spidey senses are tingling. You're thinking pancreatitis. But what's the real process going on under the hood? What is it that truly defines this disease and makes it a whole different beast than acute pancreatitis?
Okay, here's the absolute key takeaway. The most important word on this slide? Irreversible. That's the game changer. Unlike an acute attack that can, cool down and heal, chronic pancreatitis is a relentless, continuous process of scarring or fibrosis. Think of it like scar tissue just building up, and it's that fibrosis that ultimately just wrecks the pancreas, knocking out its ability to make digestive enzymes and insulin. And bam, that's where you get the two huge problems we're constantly trying to manage.
Okay, so we've established what it is, this progressive, irreversible scarring. So the next logical question, right, in any good workup, you have to ask why. Why is this happening to my patient? What's the engine driving this whole process?
And to figure that out, let me tell you, the TGAR-O mnemonic is going to be your absolute best friend. Seriously, commit this one to memory. It's a fantastic, systematic checklist you can run through right at the bedside. So you've got T for toxic stuff like alcohol and smoking, I for idiopathic, meaning we just don't know, G for genetic, A for autoimmune, R for recurrent bad bouts of acute pancreatitis, and finally O for some kind of obstruction. If you use this, I promise you're not going to miss the big causes.
Okay, so you've used TGAR-R, you've got a pretty good idea of what might be going on, a working differential. What's next? Well, now you've got to prove it. How do we get objective evidence that yes, this fibrosis and functional decline is actually happening?
And this brings us to a classic clinical crossroads. You've got two main paths. On one hand, you have the functional tests, like a secretin stimulation test. Now, these are amazing, super sensitive for catching the disease early. The catch? They're invasive and, honestly, almost never available. On the other hand, you have your structural tests, your CTs and MRIs. These are your workhorses, great for seeing late-stage damage like calcifications, but they can look totally normal in the early stages. So you see the dilemma? This is a really key decision you have to make.
All right, diagnosis is in the bag. Now the whole game shifts to management. And really, it all boils down to two main things. Goal number one, get that often debilitating pain under control. And goal number two, replace the functions the pancreas has lost, both the digestive and the hormone-making parts.
So for pain, we usually think of a stepladder approach. And step one is going to sound a little weird at first. We give pancreatic enzymes. Now the whole idea here is to kind of trick the pancreas. By giving these non-enteric-coated enzymes, they get detected way up high in the digestive system. This sends a signal back to the pancreas, basically saying, hey, you can chill out, we got this. No need to pump out so much juice. It's a negative feedback loop, and it can actually reduce pain. Now, if that doesn't cut it, that's when we move on and add in meds for neuropathic pain, like TCAs or gabapentin. But what if medical therapy just isn't cutting it, especially if you think there's a blockage? Well, that's when we start thinking about endoscopic therapy. And the goal here is super simple. Decompress the pancreatic duct. We just want to relieve the pressure. And the endoscopist can do this by yanking out stones, stretching out narrowed areas, or placing little plastic tubes called stents to keep things flowing.
And when even those endoscopic tricks aren't enough, or they just don't provide lasting relief, well, that's when we have to escalate to the next level, surgery. This is obviously a much bigger deal. We're moving beyond temporary fixes and talking about creating a whole new, permanent drainage pathway, or in some cases, even just cutting out the most diseased part of the pancreas altogether.
So the million-dollar question, which one is actually better for pain? This is so important when you're counseling your patients. Endoscopy might seem like the easier, less invasive option, but look at the data. The evidence from randomized trials is crystal clear. Surgery provides much better, much more durable long-term pain relief. I mean, look at that chart. At 5 years, the rate of complete pain relief is more than double with surgery. That is a powerful statistic you need to have in your back pocket.
Okay, let's switch gears to that other huge problem we talked about, pancreatic exocrine insufficiency, or PEI. This is what's behind that classic malabsorption, the weight loss, the greasy stools. We treat it with pancreatic enzyme replacement therapy, or PERT. But, and this is a critical, high-yield point, you have to remember the distinction. For pain, we used non-enteric-coated enzymes. For insufficiency, you absolutely must use enteric-coated ones. Why? Because these are specially designed to survive that harsh stomach acid and only release their enzymes down in the small intestine, right where the food is, so they can actually do their job.
And finally, you have to remember that managing chronic pancreatitis is a marathon, not a sprint. This is a long-term game. It's not just about the pancreas itself. It's about all the other problems that pop up because of all that chronic inflammation and scarring. So let's do a quick run-through of the big complications you've got to be on the lookout for.
The name of the game here is just constant vigilance. So let's do a quick rapid-fire review. You see a pseudocyst, leave it alone unless it's symptomatic, then you drain it. The fibrosis is squeezing the bile duct, it's going to need a stent. You find a splenic vein thrombosis, you better start worrying about nasty gastric varices, and remember, a splenectomy is curative. And if the patient develops a pancreatic fistula, your first move is usually an ERCP with a stent. Got it? Good.
And that brings us to our final thought, a kind of a forward-looking question. Look, we've gotten pretty darn good at managing all the downstream chaos that chronic pancreatitis causes. But isn't that just playing defense? The real dream, the next frontier, has to be finding ways to actually stop the fibrosis in its tracks, maybe even reverse it. Shifting our whole approach from just reacting to complications to actually preventing the disease from progressing in the first place. And that's the real challenge for the future.